Boa tarde, muito obrigado a Luís Mendao e aos organizadores da conferência por me convidarem. Eu creo que si siguiera en castellano también me podríais entender y seguramente si ho faig en català també. Pero por ser consistentes voy a hacer la presentación en Globish. ¿Okay? Aquí. Okay. Well, the title of the presentation is Community-Based Applied Research, Working Together, and basically it goes about the HIV Cobatest project. The HIV Cobatest project started 3 years ago, and it was based in different theoretical principles and some experience with it in Catalonia. So I would like just to identify some of them. One is well known. You all are aware that early diagnosis has benefits both at the individual level and at the population level. So the main objective from a public health perspective is to increase the percentage of HIV-positive people who know they are infected. But also I would like to stress that we should not forget that the main objective should be to avoid new infections. The other principle is that we know that we can do better. This is the data from the Catalan HIV registry. We collect the number of CD4 at diagnosis, and here you have the percentage of new diagnoses who are diagnosed with less than 350 CD4, which, as you know, is a criteria for late diagnosis, meaning that these persons should have been in treatment before being diagnosed. And on the other hand, below you have data from our biobehavioral surveys. We have surveys in place since 1994. And during last years, we have been collaborating with the CLN project that some of you probably know. And this is the prevalence. I don't know if I can. Is no pointer? No. Well, this is the prevalence of the infection among MSM. According to different cities. As you know, in Barcelona, we have one of the highest, being in this case about 16% HIV prevalence among MSM. And the important data is the other one. The 44% are those MSM who say they are negative, but when we analyze and linked samples, in this case saliva samples, we found them to be reactive. That means that almost half of the MSM who are infected by HIV, they don't know they are infected. So there is room for improvement. And therefore, the questions attached to the screening programs are always very operational. No? Where to test, when to test, to whom, by who, how often. On the other hand, I think we are moving from a scenario of exceptionality in terms of HIV testing towards a scenario of universalization, and the criteria accepted by the CDC, no ECDC, CDC in states has been pushing a little bit towards testing everyone who arrives to the healthcare systems in the States, and in Europe this discussion is still on the table. I do think that the more recommended thing should be to try to normalize the test, and therefore we should apply criteria of cost effectiveness and technical public health criteria. And we know some of them. We know that we should be using high sensitive and specific technologies. We know that it should have a clear potential benefit for the individual. We know that we don't need to test if we are not able to link the people to the health services. And we know that screening should be starting with high risk or high prevalence groups. So thinking about which populations need more testing, we have key populations like pregnant people, pregnant women, blood donors who are more for interests of third parties, we have at-risk groups, which is a very epidemiological concept, and we have vulnerable groups, which implies some social vulnerability. If we look how can we reach those populations, we see that for at-risk persons and vulnerable groups, usually it's much more easy to reach them outside of the health system, so in non-healthcare settings. And on the other hand, one of the objectives of translational research in public health should be to be sure that interventions reach the right populations and with the right coverage. So this is a little bit the theoretical background. About the experience in Catalonia, we have different information systems going on for many years. Some of them aim at monitoring diagnosis, so we collect data from public laboratories, both at the primary health level and the hospital level. And we also have a network of NGOs who was established in 1994, and they provide free and anonymous counseling in different scenarios and using different strategies, which is called the DEVO project. The prevalence that we found in this network is an average 2.6%. There is a screening program in a few saunas in Barcelona, which is found in 7.4%. And there is a funny program which offers testing in chemistries in Barcelona, in Catalonia, in the País Basque, in the Basque Country, which is found in less than 0.9%. What I want to just emphasize is that using the network of NGOs, this network is currently identifying 23% of all the new diagnoses done during 1 year in the region. And finally, in one of these NGOs, Checkpoint, I think tomorrow they are making more specific presentations, we have been able to put together a longitudinal study, kind of opportunistic core. So we have what the epidemiologists we are always dreaming about, no? Which is the incidence data, and what probably politicians should be asking in first place. So we can estimate about 3 per 100 persons of follow-up incidence rate, with a very significant difference between incidents from migrants and people from Spanish MSM. And the final thing that was taken into account when we designed the Cobatest project was the experience of introducing rapid testing. Rapid testing in this network of NGOs was introduced in 2006. And you can see here that after this year, a clear increase in the upload of testing in the network of NGOs. In this case, they are using Determine, which, as you know, is fingerprint-based. So in this scenario, we put together the Cobatest project. The Cobatest means HIV community-based testing practices in Europe. The purpose was to contribute to promote early HIV diagnosis in Europe by means of improving the implementation, monitoring, and evaluation of community-based counseling testing. And the specific objectives were to gain information on this program in services, to identify and describe good practices for the implementation of community-based voluntary counseling and testing, to identify a core group of indicators, to establish a network of community-based VCTs in which to perform operational research, and to assess the acceptability, feasibility, and impact of introducing oral rapid test technologies at the community level. So the main partner was our group, the CEEISCAT. The associated partners were Projectals NOMS, the Regional Center for Health Promotion in Veneto, Italy, HEIDS in France, Stop AIDS in Denmark, Institute of Sexology in Czech Republic, Institute of Public Health in Slovenia, National AIDS Center in Poland, and AIDS Hilfe in Germany. And we have a number of other collaborating partners that, as you know, in the European projects, they don't receive funds, and therefore they don't have any particular responsibility. And thanks to supplementary amount of resources from Gilead, we were able to extend the number of participating countries. So the project at the end, we include 19 countries with 13 government organizations and 15 NGOs. One of the principal limitations or difficulties of the project was to define community-based testing or non-healthcare testing. And at the end, we consensuated a definition which is a little bit sophisticated, but we think it collects both the epidemiological concepts that we wanted to be included and some of the concerns of the community who runs these services. So the definition as it states now is community-based voluntary counseling and testing is any program or service that offers HIV counseling and testing on a voluntary basis outside the formal health facilities and that has been designed to target the specific groups of the populations most at risk and is clearly adapted for and accessible to those communities. Moreover, the services should ensure the active participation of the community with the involvement of community representatives either in the planning or implementing HIV testing interventions and strategies. So it's a little bit sophisticated, but we wanted to be sure that collects what makes different community-based testing from testing at the healthcare level. The project had different deliverables, includes a national-based survey to describe what was going on in terms of community testing in Europe, a qualitative study, a code of good practice, a code of indicators, a data collection instrument, and a data collection tool. And I'm just going to say a couple of things of each one during the next slides. The quantitative report was a report that was sent to all national focal points. We got a very good response rate, but as you will see in the conclusions, the data is somehow difficult to interpret. But nevertheless, we got data about which kind of test were performing each country, how they define community-based testing, who were running these services, which kind of funding they had. So it's a general description of what the countries known is going on. In summary, we conclude that it was not a definition of community-based testing across countries, that the Cobatest definition has been accepted, but according to the data collected, it still is not sufficient specific to define and to differentiate some services. For instance, in Poland, they have community-based testing, but is run within the health services themselves. So this is some issues which are not easy to address in the definition. Also, we realized that the information was very bad at the national level. Many things were going on, but the national focal points were not informed of them. Of course, it was big difference in terms of implementation. Oral fluid tests was used very seldom. Many countries use rapid tests using blood, but only half of them, this technology was officially recommended. And although most of the analysis community-based BCTs are not specifically addressed to one particular group, MSM were targeted in most of them. The other product was the qualitative study. So there is a document. You can check all these documents in the web of the project. And the qualitative study done both with managers and users of these services identify, was of course, that these services are more friendly, the rapid test being something that the clients appreciate, the closer and non-judgment staff is something that systematically has been identified as a positive issue, objective counseling, and anonymity as well. We have defined a core group of indicators, those are the indicators. We have identified a core group of indicators that hopefully will be used in the future to monitorize and evaluate this kind of programs. And here you have an example of them, proportion of clients who report to have been tested for HIV at the same site during last 12 months. So those were aimed not only at having epidemiology data, but also at providing data who can be used for the managers of the service themselves. And here you have an example of some of the issues that are collected in the Guide of Good Practices that has identified the main characteristics that are recommended for the implementation of these services. We have also concentrated a data collection form. So most of the sites participating in the project, they have agreed that they could be able to collect a minimum data set, which is collected in this form. I don't pretend you to read it, but it collects demographic data, behavioral data, motive of attending the service. Currently, we are developing a web-based application for the sites who want to use it to collect the data. So hopefully, we will have harmonized information across Europe. And the last objective of the project is to assess the impact of introducing rapid oral fluid testing, and this is being done during this month, and before summer we are supposed to have some descriptive results on the acceptability, feasibility, and potential impact of urine or Assure, which is the test that we propose to use. So in terms of testing, I think we have still some challenges ahead. One of them is to increase the performance. I don't know if you have realized it, but the prevalence found in both the public health labs and NGOs in Catalonia is about 2–4%, and that's consistently over time, regardless of the number of tests. So probably an effort should be done to increase the number of people who are found to be infected. The discussion is on the table, as you know, to simplify and diversify counseling strategies, to increase and diversify outreach programs, precisely to be able to reach the people who are more at risk or who are more in need of being diagnosed, to ensure quality assurance in all screening programs. I think it's a polemic issue, but we should face it and we should start discussing about what may happen if in Europe the home testing is also recommended as it has been done in the States. Internet and social networks have been commented this morning. I think this is a very important tool and approach to be used on testing and counseling itself. And therefore, we have tried to identify some of these challenges, and we have put together a new proposal which was submitted last Friday to the European Commission. You can go further into detail. This is the web of the project. All documents I have mentioned are there. I just want to thank the two project managers of the project, Cristina Agustí and Laura Fernandez. And this is the new proposal that we have put together, which is called European HIV Early Diagnosis and Access to Treatment Project, Euro-HIV-EDAT, that we hope could be implemented next year and somehow will collect some of the efforts done by Cobatest. So, moltes gràcies per la seva atenció. Moltes gràcies per la seva atenció.